So Aseem, please go ahead.
So good evening, everyone. And right as I start, I would like to know how many of you are comfortable doing a hemithyroidectomy in an early differentiated thyroid cancer with a raise of hands? Regularly do, or very good. So I don't have to do anything. My work here is done. So primarily we should be talking about, should we do a hemithyroidectomy in a early low risk DTC or do a total? And we are trying to fix something that isn't broken. We know that the central compartment micrometastases are common, but with low risk disease, we might not be detecting it until they are showing up in the scans after your hemithyroidectomy, maybe after 5 to 10 years. That is why the active surveillance was being discussed. And active surveillance minded is not about your capacity as a surgeon to counsel a patient that you require a surgery or you don't require a surgery. We are talking about informed consent. Informed consent does not mean informed confusion. Now, since 2008, when Billy Moria published his first article that we should do a total thyroidectomy and not a hemi, it took 17 years to convince the crowd of thyroid surgeons that we must this conclusion to do a hemithyroidectomy. And now we are moving to the next one, that we must do a central compartment along with that. Now another 17 years will pass and we will be discussing the same thing. So we know that the disease is small, it is indolent, it is not progressing, and we are not going to operate on an invisible disease. We are going to offer a simple hemithyroidectomy or maybe a total thyroidectomy. And the written informed confusion, what I was talking about is that it took 17 years to convince you. And you are asking a patient, giving all the information about pros and cons, and expect the patient to give an informed choice. That is informed confusion with a flood of information. So we must definitely reconsider, and we must know, and we are clear that we are not going to do central compartment. First, it is a low risk disease, and majority of them are newly diagnosed differentiated thyroid cancers. A lot of them are incidentally diagnosed. And with the help of a good radiologist, you are also going to know that there are not going to be any central compartment nodes at all. So though they are node negative early diseases. And does early microscopic disease, you're finding it, do you really mean that it's going to be progressing? No. We have several trials, we have several studies, several data all over the world. These can be observed. And doing a neck dissection, is it going to improve survival? We are going to offer a surgery to a patient with a very high incidence of developing a temporary hypoparathyroidism or a recurrent laryngeal nerve palsy without any association with the increase in the survival or even in local recurrences. There is SEER database, there is a Cochrane review on that, and which support that there is no survival benefit. And still we are harping that should we do it? We don't do it. And can recurrences after thyroidectomy, are they so difficult that we'll not be able to operate them, especially after hemithyroidectomies? We have the Viola group study from in 2015. 100% of patients in the thyroidectomy alone group who developed recurrences were successfully rendered disease-free after a salvage surgery. There's a meta-analysis in 21 which showed that reoperation for recurrent or persistent DTC is safe. Another one, the multi-institutional study, there's over 90% recurrence-free survival rate in the salvage surgery group. So the recurrence is a manageable event. It is going to happen after 10 to 20 years. It's not a treatment failure, it's a course of the disease. If you are not seeing a node there in the central compartment and you are going to remove the entire tissue, soft tissue there between the carotids, from carotid to other carotid, from thyroid cartilage to the innominate, you are not going to achieve any benefit. You are going to increase the morbidity of transient hypoparathyroidism, which is reported as high as 38%. And mind you, hypoparathyroidism is one of the most underreported complications that we have. Many series have upwards of 25 to 50% complication of transient hypoparathyroidism. There is increased risk of other quality of life issues, recurrent laryngeal nerve palsies, damaged dextral branch of the laryngeal nerve, and unnecessary surgery to the patients. So we are increasing, trading harm for a questionable benefit. Versus when we do a central compartment, we are trying to prevent recurrences in some 20% of the cases, the so-called 20%. And there is a risk of 100% complications. There is possible chances of developing hypoparathyroidism, nerve palsies, and so many things. Versus we have observed, we are saving 100% of the complications. And whatever patients that are going to come, the 20% back to us, we can very well salvage them. Even the 2025 consensus, there's a recommendation that prophylactic central compartment neck dissection should not be performed. So the best and the smartest move is, when you have a low risk DTC, image it well, get a good radiologist, get the central compartment dissection, central compartment imaging done properly, evaluate them properly, so that you know that you only have to do a hemithyroidectomy or a total thyroidectomy at the max. You can follow the patient up after your surgery to detect if there are any nodal disease that are going to develop there. You can intervene whenever there is a disease. You don't have to immediately operate. So there is no survival benefit in offering a prophylactic central compartment neck dissection. You're increasing complications. And we are not talking about recurrences. There are no recurrences. Recurrences, whatever are, they're going to be salvaged very easily. So just because we are head neck surgeons, and we are also dealing with squamous cell carcinomas, it's differentiated thyroid cancers, it's indolent disease. We don't have to stress so much upon doing a neck dissection. So primum non nocere, so we don't have to do any harm to our patients. That should be our first priority. And I welcome you all to Mahamana Pandit Madan Mohan Malviya Cancer Center at Varanasi. This is a new facility there. In the last 7 years, all are welcome there. Thank you so much.